This second talk is a complete departure from the first talk, and it's more about little cases and images and asking you to guess what do you think is going on. Before I was talking to one of my nephrology friends, and I asked him to go through the images, and he got a lot of them. So I'm hoping you're going to get a lot of them, and this is a nice way to finish the afternoon and then go and have a drink in the networking reception. So let's see how well we do. There are 13 of them, I believe. And we're going to use audience response. So this is the first one. This is case one. This is an easy one, I hope. This is a biopsy. This is a 69-year-old woman with 3-month onset of malaise, weakness, who has anemia, diffuse achiness of her bones, and a workup has a creatinine of 3.8. A renal biopsy is performed. What's the diagnosis here? A, B, C, D, E are the options, and just please vote. Okay, so most people got the right answer, which was cast nephropathy. This is a patient with myeloma kidney. It isn't light chain deposition disease, because light chain deposition disease causes either glomerular damage or tubular damage, but doesn't cause disappearance in the glomeruli, these eosinophilic, relatively diffuse structures which have sort of fractures in the middle of it. This is cast nephropathy, right? And so cast nephropathy is the answer here. So multiple myeloma, as you know, is a malignant proliferation of plasma cells. More than 10% of the bone marrow is involved. And these patients get bone pain from the lytic lesions. But about 30%, one-third of patients are diagnosed incidentally while being evaluated for unrelated problems. And a third of these patients end up getting diagnosed after a pathological fracture, usually in the axial skeleton. Essentially what happens is there's overproduction of light chains, there's tubular capacity for reabsorption is exceeded, and they form casts. And these are casts, in the glomeruli, these are casts in the tubules, and the casts are these large, in dilated tubules, eosinophilic structures with fractures across them. That's cast nephropathy. Okay, case number 2. This is a 52-year-old woman who underwent thoracoabdominal resection of a right adrenal cancer. This was a patient of mine who I saw in clinic a few years ago. And she had a right periadrenal lymph node dissection and resection of the inferior vena cava. Her baseline creatinine was 0.9. 10 days after surgery, she presented with right flank pain from the time of surgery. Blood pressure was 140/82, temperature was 100 degrees Fahrenheit, white count of 18,000. She had a hematocrit of 23, serum creatinine of 1.6 that had gone up from 0.9. You see here perfusion scans. This is the left kidney, this is the right kidney. So this is the left kidney, the right kidney. This is kidney perfusion as a whole. This is cortical perfusion. And this is a CT, and just to orientate you, this is on the left, and this is the right. And the questions are, what syndrome does this patient have? Alagili syndrome, Page kidney, Benjamin syndrome, or Brody abscess? Let's do this. People seem to be struggling a little bit. Okay. So, seems like about 50%, about 57% got B, and about 30% got D. So, I think most people thought that she had some sort of problem with the kidney, which is good, right? You thought either she might have Page kidney or she had Brody abscess. Probably the Brody abscess was a guess, right? Because you thought she looks like she has an infection, right? This is the Page kidney. B, Page kidney. So Page kidney in 1959 was reported by Engel and Page in a case of hypertension associated with a renal subcapsular hematoma in a football player who'd sustained blunt trauma to the flank. And this was the first clinical correlate to Page's 1939 study of hypertension induced in dogs by wrapping one or both of the kidneys with cellophane. So this is what Page kidney is, right? It's a compression of the kidney from an external influence. And any external compression of the kidney can cause renal hypoperfusion and ischemia, which causes include bleeding secondary to trauma, surgery, a cyst, or a tumor. The preferred imaging modality is a CT of the abdomen, because the ultrasound of the kidney may not be sufficiently sensitive to detect a small subcapsular hematoma. In the case presented here, a renal scan was used to assess the differential split renal function. So you see the renal scan, and you see that the perfusion of the right kidney is markedly reduced compared to the left kidney. Oftentimes, the way I look at these things is you have to think about where the clinical symptoms are coming from. In this case, it was a resection of the right adrenal, of a right adrenal cancer, right periadrenal lymph node dissection, and resection of the inferior vena cava. She was doing fine from a kidney perspective before that. And then you look at the CT, this is the right, this is the left. I tried to help you with that. And you see this is the kidney here, and you see this rim around the kidney, which is compressing the kidney. You see that she has a blood pressure of 140/82, and you're thinking, well, what is a 140/82? It's not really that high. But in somebody who seems like they might be septic or maybe have something going on with infection, maybe a blood pressure 140/82 might be significant. But it's a real case. That's what her blood pressure was. All the other things were noise, right? I mean, Alagilik syndrome, Benjamin syndrome, Brody abscess. There's another one which I didn't throw in as a choice, but all these things are noise. And Brody's abscess is really a patient with subacute osteomyelitis. So those people who chose Brody abscess just thought abscess and just, maybe it's Brody, who cares who it is? Just going to throw it in. But anyway, this is a Page kidney. So case 3 is a 52-year-old homeless man on chronic dialysis with a history of non-compliance who presents with chest pain. The chest x-ray and the EKG show the following. And this is the chest x-ray, and this is the electrocardiogram. The next step would be administer prednisone, emergency pericardial centesis, and heparin-free daily dialysis, anticoagulate the patient immediately with heparin, administer colchicine, or administer vitamin B6. Yeah, most people got the right answer here. This is, whenever you think about a homeless man, I mean, I would say life is, not easy, right? We're stuck with stereotypes. You see, dialysis patient, homeless, you always think non-compliance, right? Isn't that what you think about? It's wrong, but that's what people think about. So this person did have non-compliance, as it turns out. And non-compliance means you think about uremia, under dialysis. One of the things that patients get when they're under dialyzed, they tend to get pericardial problems. And in fact, this patient had a pericardial effusion. You can see the sort of typical appearance. Didn't have tamponade, and the electrocardiogram shows alternans, pulse alternans or electrical alternans with the QRS complexes. You see a different height here, and that's typical of somebody with pericarditis. In fact, you don't see the concave upwards of the ST segment. That is not seen in patients with uremic pericarditis. So the correct answer is B, uremic pericarditis with or without tamponade. Uremic pericarditis is arbitrarily defined as pericarditis that develops less than 8 weeks of initiation of dialysis. That's not how we use it literally. We use it in the context of under dialysis, patients not being getting adequate solute clearance. Basically, you get inflammation of the visceral and parietal membranes of the pericardial sac. At least in the literature say usually the BUN is greater than 60, but of course, in people who are not eating and not adequately nourished, you may not get a BUN of greater than 60. Risk factors: inadequate dialysis, fluid overload, fever and pleuritic chest pain, worse than the recumbent position. Pericardial rub is generally audible but transient. This is the bane of most established nephrologists. You're rounding with fellows or residents. A resident comes to you and says, "I've heard a pericardial rub." You go in and you don't hear it. And the resident doesn't say anything, looks at you and thinks, this guy doesn't, my attending really doesn't know how to listen to the heart. He's too old, long in tooth. But it's actually probably true that it's because the rub comes and goes. And so what you do you say to the resident, put your shoulder on the resident's shoulder, put your hand on their shoulder and say, the rub from a pericarditis in dialysis patient comes and goes. So you may have heard it, but it's not there right now. And you can see whether he or she's convinced or not. The electrocardiogram generally shows absence of typical diffuse ST and T wave elevations that are normally seen in other forms of acute pericarditis, such as Dressler syndrome. And usually this is because there's a lack of penetration of the inflammatory cells into the myocardium. And this is electrical alternance, so you see a sinus tachycardia with this beat-to-beat variation in the QRS complex. The next case, you see three images. You see light microscopy, you see immunofluorescence, and you see electron microscope view. The most likely diagnosis is shown here, and you have to choose from A to E. So why don't you give it a go? So most people got membranous glomerulopathy. There was a few that thought this was membranoproliferative. I think everyone basically got the fact that there are these intramembranous immune complex deposits, right, on EM, right? You all see them? Even from a distance, you see it. You see this ribbon-like appearance, which is like granular ribbon-like appearance, typical of someone with membranous. And so the critical thing in distinguishing membranoproliferative from membranous is going to be whether you see proliferation or not. And the answer is no. You see relatively normal number of cells on light microscopy. You do see thickening of the basement membrane here, but you don't see the proliferation. So this is membranous glomerulopathy. Subepithelial immune deposition, the etiology is unknown, or obviously PLA through R is an important cause now, and we'll talk about it, but the secondary causes are many. 2/3 of the cause are not known. It occurs in about 30% of adults and about 50% of older adults. Male exceed females by 2 to 3 to 1. Most patients present with nephrotic syndrome at presentation. About 50% have hematuria, which surprises people. You think it's just nephrotic range proteinuria. In fact, you do see hematuria. So don't be taken aback if you see red cells in the urine sediment. There is an increased risk of thromboembolism, particularly if the albumin is less than 1.5. See someone with membranous, either in the boards or in practice, albumin less than 1.5, struggle in your mind about how do I prevent thrombovenous embolism, particularly pulmonary embolism. So what do? You think about, should I treat with aspirin, should I treat with low molecular weight heparin, or should I heparinize the patient completely? But think about it, particularly when the albumin is low, particularly 1.5 or lower, the risk really goes up. And you do get an insidious decline in GFR in these patients over time. Okay, case number 5. This is a 39-year-old homeless man who presents to the emergency department with anorexia, nausea, vomiting, and oliguria. 5 months earlier, he'd stopped attending his regular hemodialysis sessions. On exam, his blood pressure was 167/80, lethargic, slowed speech, and low extremity edema. His breath had urine-like odor. What's the diagnosis here? And you have 4 options. This was very easy. If you didn't get this, you're not a nephrologist. I guess, well, all of you got it. Congratulations, you'll all pass the boards. I throw this in just because it's an interesting case. I could have given you all sorts of other odd diagnoses, but this is interesting because I like the picture here. This is uremic frost. How many people have seen uremic frost in real life? Only a handful of you. Most of you are great exam takers, right? But uremic frost, this is what this patient has. First described by Hirschsprung in 1865. I don't know whether you knew that. Rarely seen because we dialyze these patients. Incidence is not known. The concentration of urea in the sweat increases greatly when the blood urea level is very high, and then evaporation of the sweat leaves a high urea concentration, and that causes the urea to crystallize. So this is crystallized urea on patient's skin. And then your scrapings of the frost can be diluted in normal saline, and then you can put it into a test tube and send it for check the urea nitrogen in it. Of course, none of us in practice have the time anymore because ding, there's the next patient is here. So you don't have time scraping it and dissolving it and all the rest of it, but make the diagnosis. Case 6. The urine sediment shows what form of crystal, and there are 5 options. So 87% of you got this as being cystine. If there is a crystal in the exam, it's going to be a cystine crystal. All right, I'm just pointing out, how many people have actually seen a cystine crystal in real life? Maybe 5 people, 6 people of the 190 people that are in this room. So it's an exam thing, right? Basically, the oxalate crystal is what you're going to see in most cases. In 80% of cases, these are the envelope-like crystals, right? That's calcium oxalate. Triple phosphate crystals are the coffin-like crystals. Uric acid will be needle-like or plate-like, but there's nothing that's going to beat the beauty of the hexagonal crystals of cystine urea, and you see they're not perfect. In the middle of it, there's this sort of dysmorphic gungy material that's also typical. Hexagonous, translucent, and white. This is just a filter that was used to show it up, so don't think that they're pink in color. Cystinuria is an autosomal recessive disorder. You're not going to need to know the genes, so I'm not going to dwell on it. Just to remember that cystinuria can result in kidney stones, but you look at these patients in the sediment, you see these hexagonal crystals. And just to show you this, the uric acid crystals, the envelope crystals in calcium oxalate, the triple phosphate crystals that look like coffins, the beautiful ammonium biurate crystals. This is the sort of thing you could have as a poster behind you in your clinic, the ammonium biurate crystal. Bilirubin crystals, this is the cystine crystal, and you see this little gungy stuff in the middle. Occasionally you might see acyclovir crystals in people who are treating with acyclovir, and then indaniver crystal if you're somebody on anti-HIV therapy. Case 7, this is a 22-year-old woman with joint and abdominal pains and a rash, rectal exam positive for occult blood, urine shows hematuria. What's the likely diagnosis, A through E? This was easy, right? Everybody got it. What else could it be? This is the palpable purpura of somebody with Henoch-Schönlein nephritis. This is, you biopsy this, you're going to see a leukocytoclastic vasculitis. These are red cells. You might see fuzziness around there. These Mickey Mouse cells, otherwise known as anisocytosis. Usually seen in people with glomerular disease. This isn't renal cancer because renal cancer is not usually associated with this vasculitic type, not renal infarction, not kidney stone. Goodpasture syndrome, generally not associated with this with a rash. So this is only one possibility, you all got it. The cells, as I said, are crenated. HSP is an IgA-mediated small vessel vasculitis, predominantly affects children. It's also seen in adults. And it's a subset of necrotizing vasculitis characterized by fibrinoid necrosis of the blood vessels and leukocytosis classes. And this is the pathology. You see this is the mesangial-proliferative nephritis, and you see deposition of IgA in the kidney. Four things, if you ever get a question, it won't be as easy as this, by the way, the question, but it brings out the four different parts of the syndrome. The skin, which is the purple non-blanching urticarial purpuric papules. When you biopsy it, you see this leukocytoclastic vasculitis. You get a small bowel vasculitis, which leads, causes abdominal pain, vomiting, diarrhea. Renal, you see in both children and adults, so we all need to know about it. And they usually present with nephritis. And joints, it's arthralgias and periarticular edema, but you don't get deformities. So it's an arthralgia. Okay, case number 8. What is the most likely diagnosis, A through E here? A little bit more of a spread here. 53, nearly half of you got renal tubal acidosis, which is the correct answer. But 47% got one of these. So, we could go through that for a few minutes. This is renal tubal acidosis, and this is the bilateral symmetric calcification in a person with nephrocalcinosis. This patient, this is a real case, was diagnosed with renal tubal acidosis at the age of 9, but didn't undergo medical follow-up for about 20 years. Other common choices are not a common cause of nephrocalcinosis. So you might say, well, I might expect to see some calcium in the urine in these patients, but they don't usually cause nephrocalcinosis. Renal tubal acidosis, different types, type 1, type 2, and type 4. You're going to cover this tomorrow with Alan Yu. We'll talk about acid-base, but briefly speaking, type 1 location is distal RTA in the collecting tubule. Type 2 is the proximal RTA. And both are associated with hypokalemia. Type 1 is associated with more acidemia, more severe acidemia. Distal RTA, this type 1 RTA is the one that's classically associated with nephrocalcinosis. And you also see bone demineralization. You can also see urinary stone formation. So just, if you see nephrocalcinosis, think about type 1 RTA. This next case, the most likely diagnosis is one of the following. About 3/4 of you got the right answer. We're on the right track. There were some who basically, I would imagine, guessed or thought maybe it was one of these other things. This is an immunofluorescence, and this is the ribbon-like continuous sort of appearance of anti-GBM nephritis. And when anti-GBM nephritis occurs, it's because anti-GBM antibodies bind an antigen in the glomerular basement membrane that's continuously expressed, and that's why you get this continuous ribbon-like. It's not the granular appearance that you see in membranous. Anti-GBM nephritis was first described by Ernest Goodpasture, or at least described some aspects of the syndrome. He was a resident in the MGH Path Department, moonlighting at the Chelsea Naval Hospital. Nowadays we even have attendings moonlighting, but he was moonlighting, and he reported autopsy findings in young sailors who presented with hemoptysis and renal failure. And this was described in case report in the American Journal of Medical Science in 1919. In 1958, Stanton and Tang used the term Goodpasture syndrome, describing hemorrhage and glomerulonephritis. And the linear staining was on immunofluorescence in this way was described by Shear and Grossman in the Annals of Internal Medicine, 1964. Very uncommon. 1 in a million or less, 1 in 10 million cases. I've seen about 6 or 7 in the 35 years I've practiced. 1 to 2% of renal biopsy specimens. I think the most remarkable aspect that you should just be cautious about is sometimes they present in the history an upper respiratory prodrome, which occurs in the literature in about 50 to 75% of cases that are reported. And usually you think, this must be a vasculitis, an ANCA-associated vasculitis. Don't be misled by that. Also, some patients can have fever, rash, myalgias, malaise, headaches, weight loss. Not clear. In the cases I've seen, I've seen the fever, I've seen the malaise, I haven't seen a rash, but I've only seen maybe half a dozen cases in real life. Presentation is with a really fulminant renal failure, rapidly progressive glomerulonephritis, and these patients have no time to develop hypertension. They usually have some proteinuria, but not nephrotic range proteinuria. Renal ultrasound is normal, and the renal function declines rapidly. Case 10 is a 48-year-old white male with chronic kidney disease with a serum creatinine 1.5 who presents to you complaining of weakness and fatigue and an episode of palpitations. The patient is on furosemide, lisinopril, atorvastatin, and aspirin. You do an electrocardiogram and draw labs. Based on the EKG, what's the most likely diagnosis? This is the electrocardiogram, and you have 4 possible scenarios. In your notes, you see a bigger EKG, so you should be able to look at it. And you just have to choose between these 4 options. So about 57%, about half of the people chose hypokalemia as the correct answer, which is the correct answer. But there were others, 21% thought this patient may have hyperkalemia. I guess those are the people who just thought, if you're going to present an EKG with someone, they're going to probably have hyperkalemia. The patients on lisinopril must be hyperkalemia. It isn't hyperkalemia, sad, unfortunately. And this patient doesn't have hypomagnesemia, although we always blame magnesium for the cause, right? This is the electrocardiogram, and here you see the abnormality. This is a U wave. This is a U wave, and this is asked in board review questions all the time. Here, I took it from the cardiology board review section on the internet, but this is a U wave. This just shows you the different changes. This is P, QRS, and T with this a normal tracing. Hypokalemia, you see the U wave here. There are more subtle changes. You might get a little bit of ST depression in patients with hypokalemia, in addition to the U wave. And the U wave is associated usually with a shallow T wave, and that's why you don't think of this as being hyperkalemia, where you see these, really pinch bottom T waves. Hypocalcemia and hypercalcemia, this is not relevant to this case at all. Hypokalemia, PR interval may be prolonged, flat T wave, prominent U wave, maybe a little bit of a touch of ST depression. Usually, at least the real experts think that you might see QT prolongation, but actually it's very difficult to measure that. We're almost done. Case 11, 20-year-old man presents with edema, history of painless gross hematuria, age of 16 and 18, denies joint pains, mouth ulcers, hemoptysis, abdominal symptoms. Exam is normal except for a little bit of hypertension. He has some pitting edema, 2+ blood and 4+ albumin. His sediment shows dysmorphic red cells but no red cell casts. Complements are normal. Renal biopsy is shown. What do you think the diagnosis is? Yeah, that's correct. This is IgA nephropathy, so most people got it. This is the mesangial changes that you see, and you see the mesangial deposition. IgA nephropathy usually occurs in young people. Seems to be more commonly reported in people from the Far East, but they have different biopsy practices there. Everybody with hematuria gets biopsied. We don't biopsy everyone hematuria, so that may be really a reflection of practice rather than of what actually occurs. Macroscopic hematuria, microscopic hematuria can occur. The hematuria that occurs macroscopically is pharyngitic. So remember, if you get a case, if there's a 2-week lag, that's usually somebody with post-strep GN or post-infectious causes of glomerulonephritis. This is post-strep. This is not post-strep because this is synpharyngitic. And the syndromes can be macroscopic hematuria, microscopic hematuria, RPGN, or nephrotic syndrome. So you could be presented this in many different flavors. Case 12, this is a 56-year-old woman with hypertension, sudden onset of painless impaired vision in the right eye. This is what you see in the right eye after you've consulted or you've been consulted for her clinical features. She'd undergone a cardiac catheterization for evaluation of hypertensive emergency. On physical examination, the visual acuity in the right eye was 20/100 with significant visual field defects in the inferior temporal quadrant. What do you think this is? And I'm going to give it to you. It's a cholesterol embolism. And you see this boat-shaped infarct. And this is what you see. These are the cholesterol spicules that dissolve away as you fix the biopsy specimen. You can also see this with this little sort of dusky discoloration in the feet. You have pulse. You may lose pulses in the feet. So oftentimes when we walk around on consult, somebody consults us. It's often really helpful to look at the feet. You can see these occur in middle-aged to elderly people. They have more vascular disease, men more than women. You might see stepwise rise in the serum creatinine. And bland urine is usually classic, but you can see abnormalities in the urine. And this has been reported by some of my colleagues at the Mass General. And the last case is case number 13. This is a 64-year-old patient with ESRD on hemodialysis, presents with ulcerative painful lesion. She said she started off as a reddish rash and then evolved into an ulcer over the ensuing few weeks. The most likely way to reach a definitive diagnosis would be, and there are 5 options here, if you could choose. And that's correct. Skin biopsy is the correct answer. This is exactly right. This person has calcific uremic arteriolopathy, which is otherwise known as calciphylaxis. There's different versions here seen. You can see here the biopsy. 1 to 4.5% of patients on dialysis can see this. The classical picture is that of an initial skin lesion, a livedo reticularis-like lesion on the lower limbs, which then progresses to violaceous, painful plaque or subcutaneous nodules, and then ischemic necrotic ulcers in a reticular pattern like this. There's a differential diagnosis to this, of which I think the most common ones that I always think about is Coumadin. These patients have severe pain, they're miserable, and rightly so. They have these non-healing ulcerations, recurrent hospitalization. They have a very high 1-year mortality, 40 to 80%, and the skin biopsy confirms this arteriolar calcification and mural thrombosis, which is then associated with a septal paniculitis. And the treatment, there are many different things, but I think one of my colleagues here at the Mass General, Sagar Nigwakar, who's collecting these cases, so if you have cases, send them to him. Sodium thiosulfate is the one that most of us are thinking and using because of the terrible prognosis and how miserable these patients are. And you dissolve, you give doses over 1 hour post-dialysis.